welcome to Conversations with. I'm Courtney.
And I'm Keith.
And we are the clinical team here at Burtons Academy. With our combined passion for monitoring and ventilation, we're here to rewind and remind you on the foundations and principles used to form the knowledge and understanding in everyday anaesthesia. And in this week's episode, we're talking about oxygen monitoring. So in the first two episodes of Series 3, we discussed how to give oxygen to our patients and also how the oxygen goes from our patient's nose, from their mouth, all the way down their airway and into the cell, right down to the mitochondria. So I'm joined by Keith this week, and we're just going to be covering now and looking into different ways that we can monitor our patients' oxygen levels and the concentration that we're giving to them. So welcome, Keith.
Hello, everybody. Yes, thanks, Courtney. Yeah, I think hopefully this will be an episode that brings together what we've talked about in the last two and becomes a bit, more applied now. We're talking about oxygen. So I think one of the things maybe we can start to look at with oxygen is how do we assess all the things we talked about? Because basically what we talked about is, can we get enough oxygen, into our apparatus? Can we get it into the lungs? Can we get it down to the cells? And having understood those pathways, how do we, as clinicians and people monitoring anesthesia, how do we check that we've actually got those processes working, that they're actually doing what they should be doing? Because we're talking about oxygen. So what we're concerned with is hypoxia. And I think we mentioned last week that hypoxia is a swift killer as opposed to hypercapnia or hypocapnia, which are much more prolonged. So it's quite an important thing. We need to be on top of hypoxia. So one of the first things I think people are going to say is pulse oximetry. And I'm going to say yes, but I think before we start talking about that, we should look at some of the fundamentals. How can we look at a patient and assess its ventilation and therefore imply its oxygen delivery and suitability? How are we delivering the oxygen? So let's just go on what we can see and what we can actually assess ourselves before we start looking at things like pulse oximetry. So let's lift up the lip and let's have a look at the lip, because we're looking at those mucous membranes, and let's see what we can tell there. So there's going to be a number of things. So what we'd like to see is a nice pink, flush, turgid, gum line really, and you're going to put your finger on it, push it, and it's going to blanch, and then it's going to come back. So we've got assessment there of colour. We've got assessment there of some degree of circulation. So the colour is what we're really interested in, because we're going to looking for a nice, healthy, blush pink. And that's going to suggest that we've got lots of oxygenated haemoglobin in the blood. It's going to give it that colour. Because if we got a lot of deoxygenated haemoglobin, we're going to tend towards a blue colour, because oxygenated haemoglobin is bright red and deoxygenated haemoglobin is more tending towards the violet and blue. So we'll see that, and I think we've all probably been familiar with that. So we're looking for that bluish colour to suggest we've got some degree of hypoxia. So that's the first thing we can look at. And the other thing we could also observe is that there may well be paleness to those mucous membranes. So that could be a number of things, but it could be anemia. And then if we've got anemia, we've got a lack of hemoglobin. So we're not carrying the oxygen around. So we've got a potential anemic hypoxia. So we're looking at, just by lifting that lip, we could possibly begin to suspect things like circulatory hypoxia, because, your refill time is poor. We could be thinking about maybe an anemic hypoxia because they're pale, and we could even be thinking about maybe one of the toxic hypoxias, because if it's cherry red, and I've never seen it, I don't know how prevalent it actually is. I've never seen the cherry red, or I've seen what may have been carbon monoxide poisonings. But if it is, bright red, vibrant red, then we got a cytotoxic hypoxia. So there's or a toxic hypoxia. So even just by observing, we can look at those potential hypoxic causes. So that then begs the question, doesn't it? If you suspect hypoxia, how do you confirm it? And then the last question is, having confirmed it, how do you deal with it? How do you treat it? How do you respond? So I suppose we ought to deal with the most common thing. So let's deal with the most obvious thing, the hypoxia due to hypoventilation. That's going to be I think, the most common that you're going to see, because you've anesthetized a patient, you've suppressed its respiratory centers, by whatever agents you've used. And so you've got a hypoventilation. So that hypoventilation is going to potentially lead to a hypoxia. So I think we talked about it. Maybe it's the first episode of this oxygen series. We talked about, if you had a hypoxia due to hypoventilation, then the simplest thing to do is to increase the delivered oxygen fraction up to about 30-35%. So the first thing, if we suspect a hypoxia, would be to get it onto oxygen. Now, that's probably going to be the case anyway. We'd have anesthetized, intubated, and then put it onto 100% oxygen, or close to 100% oxygen. And by close, we've got to think about nowadays oxygen concentrators. And they don't deliver 100% oxygen. They deliver somewhere between sort of 95, 93. I think they vary between 93 and 97. So you're getting pretty good oxygen levels, certainly enough to overcome any problems with hypoventilation. So as long as your patient is taking a breath every now and again, it's not going to be hypoxic due to lack of oxygen being delivered. So the other possibility, there are only two causes of true hypoxia. That's going to be hypoventilation and shunts. Mm-hmm. Yeah. And again, we talked about that last time. I did come across some interesting facts that if you have a shunt of more than 30% of the cardiac output is shunted, you cannot compensate for it by 100% oxygen. That's the limit. So up to 30% shunt. So if your shunt rises above that, your shunt fraction is more than 30%. Doesn't matter how much oxygen you give at atmospheric pressure, you won't overcome it. So there'll always be a degree of hypoxia. So shunt's probably something we see with anatomical problems. I guess the arterial shunts that persist after birth, and in the larger animals, particularly we talked about horses, and I guess this would apply to big animals, certainly apply to cattle and possibly sheep, and maybe to big dogs where you've got those physical forces acting on dependent lungs. So you've got shunts going on there. So if you are looking at hypoxia, then you can only compensate so much by running 100% oxygen. If it's caused by a shunt, hypoventilation, you shouldn't see it once you go over 30-35%. So we've got to, or we've been able to sort of imply or infer low oxygen delivery, so hypoxia, just by looking at the patient. But we've now got these other tools as well. So there are some, we got the pulse oximetry, we got blood gas analysis. So maybe we'll now have a little think about pulse oximetry. We're not going to go into this in too much detail because I'm hoping that Courtney and I can have a nice podcast itself on pulse oximetry. I think it lends itself to a whole podcast. There's so much to talk about. But just for now, we'll look at the practical side of what that pulse oximeter is telling us and what information we can glean from it. So I think maybe for this, Courtney, I'll let you maybe talk about some of the limitations of pulse oximetry, because we put it on the tongue, we put it on the toe or wherever we put it, and we assume that we're going to get, the value we're going to see is going to be absolutely what the saturation is. But I think all of us, everybody who's ever used a pulse ox been in that theatre, when it says, 87%, I'm not going to believe it that first time, are we? It's not right, because the first thing anybody's going to do is question that, move the pulse ox, reposition or whatever, and then just see if you get the same reading again. If you persistently get 87%, then you might start to believe it. But there are a few other reasons why we might see poor values, I think. And I think you got some thoughts on that as well.
Yeah, I really do like talking about pulse oximetry, and like you said, I need to not get carried away, because it would be great as a podcast. And Keith and I have actually also put together an article, a clinical article, I think sometime last year, on pulse oximetry. So if you haven't read that, we can talk about that next time. And if you haven't read that, you can also, we'll link it into this blog as well. But pulse oximetry, I quite like pre and post anesthesia in regards to if my patient's potentially hypoventilating. And I like to use the pulse ox in recovery because that's truly where a lot of our patients are hypoventilating because of the anesthetic drugs that are left over, because they're really cold. Perhaps there's a bit of thoracic pain. So when they take it, they don't want to take those deep breaths in because it hurts them quite a lot. So I quite like using it in the recovery period. And I'm sure you'll agree, Keith, we've got to be careful here almost, but using it intra-op in a healthy patient, it's more of a like heart rate counter almost, because we're providing such a high flow, high concentration of oxygen. To see those differences in the theatre on our pulse ox, if it does read that 92 or 91, either on such a high concentration of oxygen, is it really real? And I know when we have our student nurses in the theatres as well, and they're doing a lot of scribing for us, and they're writing down all of the values on the anaesthetic, from the machine to the anaesthetic record. Sometimes they'll just write, and then they'll see that number that should be above 95, and they think, oh, I'll write that down, but actually let's start troubleshooting that.
Yeah, I just think there's one thing before we go too far, let's just think about what pulse ox does, because I think people might be surprised what a pulse ox does. So a pulse ox is very good at determining oxygenation, actually percentage of oxygenation, but has very little information on the amount of oxygen being carried in the blood. I think those two are very different. Maybe we can just clarify that before you carry on with what you were saying. So this is the nature of these podcasts, that things come to mind and you just kind of need to, if I don't say it now, I'll forget about it. I won't talk about it. So just to clarify, so a pulse ox will determine the level of oxygenation, the level of saturation. Yeah. So if you have, say, a packed cell volume of 30%, PCV is 30%. So you've got plenty of red blood cells in there, yeah, and they're all 97% saturated. Then obviously you can infer from that it's carrying a lot of oxygen, able to carry a lot of oxygen. But say your PCV was 18%, and there's still going to be, all the ones that are there are going to be 100% saturated, 97% saturated. So they're still going to give you a nice percentage on your pulse ox with a carrying capacity of that 18% now PCV compared to 30% is way, way down, because you've just got less red blood cells. So an anemic patient might show that it has a good saturation, but it'll still be hypoxic and suffer.
Even if it's carrying just one red blood cell, that one red blood cell might be oxygenating, or 100%. And you look at your reading and you go, oh, that's fantastic.
It's 100%, yeah. So it is a very good indicator of saturation, and assuming you've got no other pathology going on, then that's fine. But you have to bear in mind that if there aren't enough red blood cells, it'll still look like it's very well saturated, which indeed it is, but there just isn't enough oxygen carriage going on. So just wanted to make clear that the pulse ox isn't a wonder monitor. It's got its limitations. So all we're really looking at is the percentage of saturation of whatever happens to be there. So I also want to make that point, really.
No, I think it's really important, because anemia is certainly, I've had those cases before where you have thought, okay, this patient's got we're doing a bone marrow biopsy, for example, and they have a PCV. These cats, they're not so bad when their PCV is 9%. If you've got a 9% PCV dog, they're on the floor and, I'm in deep trouble. But these cats kind of go, oh yeah, I've had this 9% for 3-4 weeks. Why are you panicking? And then you go and put that pulse ox probe on them, and their pulse oximetry is normal, and you think, oh, this is fantastic. But actually, like you just explained, it just takes 1 or 2 red blood cells to make that reading really nice and normal. So it's definitely, there is a limitation with anemia. And I find also, when you were talking about flipping the lip to observe the mucous membrane colour, we do want that really nice blush pink. But in those cases of anemia where there's just not enough red blood cells to make that look nice and pink, or if they've got hypotension or hypothermia as well, flipping the lip and having a look doesn't really give us too much information. And also, we can't see the bluish colour for quite some time of cyanosis, can we?
Absolutely. Yeah. I mean, again, looked at some studies with that, and detection of cyanosis has actually been looked into a lot, and it's very, very difficult to do. And it's influenced by all sorts of things. It's influenced by skin color. It's influenced by lighting, sunlight versus fluorescent lights, and versus tungsten lights, and the different colors of lights. And in fact, I think the generally accepted view is that unless you get down to saturation of 83% or less, it's very, very difficult to be accurate about diagnosis.
And then we're in danger zone. And you know what?
Yeah.
I know this fantastic vet, and his name is, he sits in, and I know he's got a problem with colours.
Yes, exactly. Yeah, yes. So,
if you've ever been to our talks and Keith's trying to use a laser pointer, and he's like, I'm sure it's up there somewhere, I just can't see the colour.
I do struggle a little bit with red and green. So, yeah. So,
oh, okay. The blue's fine.
So, blue's fine. Yeah, I can see blue. Yeah.
Okay. Lucky for our patients then. But there's definitely some limitations on pulse oximetry. The thing I like about it is because it does give you, under anesthesia, a nice audible pulse. So actually, there is in that really big, nice STEP study on morbidity and mortality, by using a pulse oximeter, we have a reduction in risk for our patients, and that's because we can hear a pulse. But using it under anesthesia versus in the pre-op or post-op phase, I think for me is where I have more trust in it. Like when should we trust the pulse ox machine? I know this isn't going to be a pulse ox podcast, but when should we actually trust it? And I think when I apply the probe onto my patient, I'm trying to pick a nice, like fleshy bit of the skin, not too thick, not like the back of the tongue where it's nice and chunky, but perhaps the more tipped part of the tongue. Hopefully I'm not going to have a probe that pushes all of the blood out. I quite like using it on toes and prepuce and webbing of the feet and vulva. I like putting it there out of the way. But in terms of trusting my pulse ox, to be honest, whenever I see an abnormal number, I just reposition it and go from there, because I'm thinking under anesthesia, it really shouldn't be dropping that much.
No, exactly. It's got to be something really, really significant, hasn't it, for that saturation to drop?
Yeah.
Anesthesia. When we say under anesthesia, we mean 100% oxygen being supplied, or very, very high levels of oxygen. So it's going to be very severe by the time you see a true hypoxia from, or drop in saturation from that. Mm-hmm. But just coming back to the anemia thing, we can have a nice saturation, but we can still have a patient that's in a degree of hypoxia. Mm-hmm. And as such, not getting enough oxygen to the tissues. We'll come on to that maybe in a while as to what that actually means. But so it's a good pulse counter. It does give you an indication of some degree of pulse volume, but we'll cover that as well when we do our podcast. But it's one of the tools that we think is our go-to for assessing oxygen delivery to the patient, but it's got its limitations.
Yeah. I think if in doubt, we can always use our, same thing with capnography, isn't it? And our pulse ox. It's non-invasive ways of measuring these things. And then if in doubt, we can take a blood gas sample if that's available to our practice and actually confirm perhaps what our readings actually are.
Yeah, and I think that's interesting, because really the next step, one of the things we can use to monitor would be blood gas. But I just wonder how many first opinion practices are doing blood gas analysis.
I don't think many, and I mean, if you definitely have it in practice, message through and just let us know. But surely I still locum on the weekends, and I go into loads of different practices, and I definitely don't feel like it's at many general practice. And then also in the practices where we do have it, I find that we're using it for really quick readings of like potassium, like a single potassium reading, versus doing these true blood gas analysis. So yeah, I don't think it's as prevalent yet, which maybe things will change.
Yeah. So from that, really, then there are a lot of practices, first opinion practices, what remain of the independents and what have you, and some of the smaller practices that are going to be relying on pulse ox for their oxygen assessment, aren't they? And But what's the practical implication of that? What are they going to do if it does say 93%, and they reposition and whatever, and it still says 93 and it's continuing to fall? So there must be something there that's affecting oxygen saturation. Yeah. And there are only two causes. The only two causes are hypoventilation and shunt. And it may well be that the case itself is, would suggest there's the high percentage of shunt. But if not, it's hypoventilation. So the simple thing for those is to ventilate the patients either mechanically, but it doesn't have to be. It can just be manual IPPV. And the first thing I would suggest that anybody do, all this theory aside, if the patient is, the monitoring equipment, the pulse ox is suggesting that it's hypoventilating because it's got reduced saturation, then ventilate it manually. Double its ventilation rate. If you double its ventilation rate, it should improve its saturation. If it doesn't, then there's another cause. It's not the ventilation rate. Doesn't mean you should stop ventilating, because it may well need that extra anyway. But that, in practical terms, there aren't many things other that you can do.
I often think in my patients that are under anesthesia that have suddenly become, or the pulse ox is trended down and it's telling me that they're hypoxemic. Now, correct me if I'm wrong, but perhaps this is just how my brain's been thinking of it for a few years. When I've been providing that 100% oxygen as well, and often as that trend goes down, the first thing I start to think about, or in my head, I trigger straight away, oxygen delivery is impaired. Am I going to start ventilating? Am I going to give those puffs of those puffs? Am I going to start giving them some manual breaths? But then I also think, am I just not supplying enough oxygen? And that's when I look over and you can see that the flow meter has been knocked down. Or actually, I even had an instance where the nitrous oxide, it was one of those electronic flow meters.
Okay.
So it's quite easy just to hit the knob and suddenly nitrous was being delivered to my patient as well. But also, have I not perhaps done enough, removed the room air out of my vocal system? I just start to think, is oxygen delivery somehow impaired as well?
Yeah, that was a brilliant point, really, Courtney. Absolutely. We made the assumption, haven't we, that the oxygen going to the patient is what we've either delivered, set up on the machine or the concentrator or whatever. But there's a lot of factors that we discussed before that could go wrong. And I'm absolutely right. Someone turns the nitrous up, someone turns the oxygen down. All sorts of things can happen. So it would be really nice in the absence of blood gas, which you don't have to have. What would give you far more confidence would be something that told you the inspired oxygen concentration for your patient. Actually told you what it was. At the moment, we're expecting it to be, nearer the 90 to 100%. But in a circle, that wouldn't be the case for all sorts of reasons. And just as you described, it wouldn't necessarily be the case on an on-rebreathing system if the oxygen cylinders run down or there's some other gas being introduced. So absolutely right. And they are cheap now. To count an oxygen analyzer, not on a breath-to-breath basis as part of a multi-parameter, but just standalone oxygen measurement, just to measure the incoming oxygen, the incoming oxygen, the FiO2 to the patient. Put it on the outlet from the circle, put it on the fresh gas outlet from an anesthetic machine, just so you can see that it says, 90%, 93%, or whatever it would be. But in your instance where you see that 87%, what? 87% saturation. You think, well, why? Why would that be the case? You glance over at your anesthetic machine and you see that the oxygen value coming out from your analyzer is now, 58%, because something has affected either there's a leak between the concentrator and the delivery, or there's some other gas being introduced, just as you explained. Really easy to put one of those in. Without blowing my own trumpet, I did make that little icon analyzer years ago because that was something I was really interested in, to have something that was easy to put into the circuit to measure inspired oxygen levels without having to go to the expense of having that as part of the multi-parameter. Because normally it's about £1,000 to £1,500 to be able to measure breath-to-breath oxygen. And you don't need breath-to-breath oxygen. You only need to know the inspired, really. So, yeah, sorry, kind of interrupted you a little bit there.
Oh, no, no, it's fine.
But you're right. Yeah. If you see that 87%, yeah.
I start to think, okay, is my patient okay? Like, why would they spontaneously go from saturating really well to suddenly not saturating in those healthy patients? And I think, there's got to be something wrong with delivery here. And that's when I just turn my attention straight to the flow meter, straight to the gases that have been delivered, and just wanted to make sure that actually what I had set the flow meter to hasn't been knocked by somebody, that there is still gas in the cylinder or the oxygen concentrator still doing its thing. And yeah, you can. I love the icon. I like when we say I'm not going to blow. I don't want to blow my own trumpet, but I want to blow the trumpet. It's a fantastic little device. I think we talked about it quite a lot when we were discussing monitoring the concentration of oxygen in these oxygen tents as well, that you can use it. So
yeah,
I absolutely love them.
Yeah. So we need that. We need something, don't we, to kind of back up what that pulse ox is saying. And the first response is, as you said, reposition. Because if we get a repeated value, then you tend to start to believe it, and then we'd work on that.
Okay. And I think last night we talked, when we had a little catch up last night, just to talk about the weekend, we also got into our nerdy wormhole and said basically that by the time you see a reading on your pulse ox, it's actually quite a delayed reading. It's not that breath and then suddenly it falls really low in that instance. So the reading that's on our pulse ox is actually quite some time because of it's placed on the periphery. So therefore it's got to be something that happened in that patient's lungs or didn't happen in that patient's lungs about 20 or so seconds prior. And then you also mentioned last night, that it could also, by then, something's happened. They've used up all of that really rich oxygen in their functional residual capacity or functional reserve. And then finally, it gets way out to the periphery for us to read, and it's low. So actually, it could be a delay that's like 30 seconds ago. So hurry. If you truly see those problems, hurry, because it happened a while ago. And I think I like to apply that in the recovery period, actually. If you start to see this trend down, because I've got a really cool video of a bulldog trending down in the pulse, trending down in the recovery period. And then when it gets to like 80, 88 or so, we thought, let's intervene. But now I'm thinking in my head, I should have hurried. Oh, that was a 30-second ago indicator. He's probably even worse and worse and worse. So actually, it's not, even your pulse ox isn't giving you breath-to-breath oxygenation status. There's still quite a delay in that as well.
Yeah, because basically the blood will continue to be oxygenated while there's a reserve in the lung. While the FRC holds oxygen at the 21 or 100%, it will continue to pick it up and maintain that saturation. So only when it starts to fall, when there's no longer any oxygen left in the body when there's not enough oxygen left in the lungs to further properly saturate the haemoglobin, then it starts to show. At that point, of course, the oxygen reserve in the lung has all been used up. So you're in a state of hypoxia already, where you've been heading towards it. So you won't see it for a long time. And by the time you see it, you're absolutely right. Whatever event happened quite a while ago, because it's used up all that reserve before you see the effect. So it could have become completely apneic a while ago, or its tube could have come disconnected under the drape a long while ago, or blocked, or whatever, some time ago.
And that's actually another good point you just made about the ET tube being blocked. When we talk about why is delivery not happening in our patient, is the head kinked?
Yeah.
All of these things, that fall into place.
Yeah. So, okay, so I think we may have slated the pulse ox.
That is great. It's great.
It does have its place, but it does have, it certainly has its limitations. I think that's recognised in the medical field. They don't rely that heavily on it. It's a really good guide. Obviously, during COVID, it was a really good indicator, because COVID was a condition which really led to diffusion limiting of oxygen. We talked about that before. So that was a really good indicator. Okay, so we're not going to steal the thunder on our pulse ox podcast. So, but maybe just to say something about the different types of pulse ox. We've got transition, we've got reflectors, and maybe that I'll just explain the difference between those two. The transmission is the typical through the tissue. So you have a clip type that had a light on one side and a sensor on the other, and it'll transmit two different light sources, different wavelengths through the tissue, picked up on the other side, and it analyzes the difference in the absorption between those two wavelengths. It's going from one side to the other. So whatever you find a bit of tongue, you put it on ears if you can. You put it across toes. You put it across the feet of a rat. You put it across the foot of a mouse. You put it across anything that will just trap a bit of arterial pulsing tissue. And it works. That's it. That's the whole point of a pulse oximeter. It only picks up the pulse. And then there's the reflectance type, and reflectance type has the emitter and the sensor on the same piece of material. So in other words, you've got like a little square of material that holds the two, or a plastic that holds the two sensor and emitter, or it can be more longitudinal like the rectal types. But essentially, it sends out a light, and we'll only get that light back if it goes into tissue, sees something optically reflective, and normally that's bone, ligament, or something like that, and that gets reflected back through the tissue again and picked up by the sensor next to the original emitter. So it goes in and comes back out again, hence the reflectors. But I love the reflectors probe.
But they use reflectors on baby feet as well, I think.
Yeah, they do. They have these little pediatric ones that adhesive that wrap around, and they use the reflectance one there. Absolutely, yeah. They work well. And it works on our dogs. You can use reflectance. I've used reflectance probes on black Labradors. You clip for the vein on to give you IV on your Labrador, and it's got that black skin. But you can still get quite a good reading if you put that pulse ox there and pick up the brachial artery or the radial artery down there. It still works quite well. But yeah, down the ear is nice because it if you clean the ear, get the wax out of the way, and put it against the medial wall, then you pick up the pulse there. You pick up pulse on the coccygeal artery. Lots of lovely places to put it. And because of all the work I used to do with exotics, it's a bit of an art using a reflectance probe. But you can put it on the brachial artery for birds. You can put it on metatarsal artery for birds. All sorts of places you can put it. And the nice thing about it, compared to the transmission, is it's not the technology. It's the way it's held in place. The transmission has a spring to hold it in place. It slowly compresses the tissue, which exsanguinates it. Well, not exsanguinates it, but it just reduces flow. Whereas the reflectance, because it doesn't have that continual pressure, and you just hold it in place with a bit of cotton wool, it just sits there and picks it up and continues to give you a good reading. So yeah.
You know what's in my mind? I'm always traumatized by trying to use pulse oximetry on a chow chow. And so now I'm thinking, what colour is the inside of a chow chow's ear? Because actually that might be, you can't find a spot that's not pigmented on those guys. Their tongue, their vulva, their everything. It's just this black tongue, this black everything. And you think, I can't get a reading anywhere. So I wonder actually, next time I'm going to take note of the chow chow there and consider a nice reflectance probe.
Yeah, they're quite fluffy, their ears, aren't they? I wonder if there might be quite a lot of hair there, but they're big. I mean, they're certainly big enough to get a reflectance probe down there. Yeah. The ones I'm familiar with, and especially the non-em probes that work really well, they'll go down there. So yeah.
That's been that they're about the same size as your thumbnail, really, haven't they? Those probes, they're quite convenient.
Even smaller than that, really. Yeah. About 7 millimeters by about 5 millimeters, something like that. About 3 millimeters to 4 millimeters deep. Yeah, they're quite small. Yeah. And then I normally put a bit of cotton wool down the ear, clean out the wax against the medial side, and then put the probe down and hold it in place with another bit of cotton wool. Or in horses, I'll stick it up their nose and have a bit of sponge that just goes up the nose and pushes I say sponge, it's like a foam. You just compress the foam, push it up behind the pulse ox that you put against the nasal septum, and then just let it go. And it just holds the reflectance probe against the nasal septum. Get lovely traces in horses doing that, which doesn't deteriorate over time. That's a nice thing. It doesn't deteriorate over time. So, but we'll again, this is straying in.
We shall not spoil the next podcast plan by talking about the pulse ox.
No. So one of the last things maybe to talk about the influence or hidden things that might happen with pulse ox. We talked about methemoglobin a bit last time and carboxyhemoglobin. So carbon monoxide poisoning and what it would do to a pulse ox. It doesn't actually change the saturation value. You could have quite a lot of carboxyhemoglobin, but you'd still get normal saturation levels. And again, this being one of the practical sessions, we were going to talk about what you would do. And it's interesting with carbon monoxide poisoning that there's not a lot you can do other than put them on 100% oxygen. But just as a complete aside, just because I was reading something that I thought was interesting, is that the treatment for carbon monoxide poisoning is to put them on 100% oxygen because the half-life of carboxyhemoglobin is about 320 minutes in room air, in 21% oxygen. But actually, exposure to greater levels of oxygen reduces that half-life. So if you're near 100%, it reduces that to about 80 minutes, 75 to 80 minutes. And even for the severe cases, they put them in a hyperbaric chamber up to about 3 atmospheres, and that reduces the half-life of carboxyhemoglobin down to about 20 minutes. So if you get it down to 20 minutes and you get the half-life down to that sort of level, then the recovery time just gets faster and faster. But it's quite interesting how extreme you've got to be to treat these animals. It's not, it's not enough just to give them extra oxygen. I mean, it's the first step, but for our patients, it's probably the only step, because I'm not sure that we'd be able to get them to a hyperbaric chamber. And apparently, if you don't get them there within 5 to 6 hours, the benefit will be lost anyway. So you're going to be fairly swift to do that. So that's carbon monoxide. Is there anything else we need to talk about with pulse ox before we move on?
No, I think we can save the in-depth stuff about pulse oximetry for later. But I think in terms of practical use, I feel like we've quite happily rounded up how to use it. We can peri, post anesthesia limitations with that. So yeah, I think we could definitely talk about other ways that we see oxygen in everyday anesthesia.
So let's talk about circle systems, because I think they have a potential for inducing hypoxia through misuse or even misunderstanding of their use. And I think one of the things that I talk to a lot of nurses and a lot of vets about, and they all talk about the denitrogenation period, but I'm not sure that it's that fully understood. I think people know it occurs, but the mechanism and what happens during that period is perhaps not understood. Mm-hmm. Would you like to sort of go through the sort of denitrogenation sort of sequence with a circle?
Yeah. I think it sounds like a really big scary word, doesn't it?
Yes.
And you think denitrogenation. What is that? What am I doing? And I believe it or not, if you're using a circle system, you're already removing the nitrogen from it by having that increase in fresh gas flow. So you're already doing it. But did you know there was actually a term for it, basically? So what we do with our circle system is it's a huge system, isn't it? You've got tubing, you've got the CO2 canister, you've got a reservoir bag there as well, and that's all full of room air. And if we kind of think about numbers, we know that room air is about 21% oxygen, and then there's nitrogen in that room air, about 79% oxygen. And we have to get that nitrogen out and then fill up that whole system with 100% oxygen, or as close to as possible, for our patient's anesthesia. So every time we do this, we do it every single time we use the circle system. I'm sure you just perhaps didn't know there was a term for it. We increase that fresh gas flow for the first kind of 10 or 15 minutes. And what we're doing in that time is we're pushing out all of the nitrogen that's in the room air there, filling it up with 100% or close to oxygen, as well as our volatile agent. And we have to have it at that nice high rate because the volume of the system, and we need to ensure that we're pushing it all out. But also our patients' lungs are still full of this room air as well prior to being anesthetized. So they breathe out into that system. So about 10 to 15 minutes, we have this high flow of oxygen going into our circle system. And of course, in anesthesia, we love to put a number on things just to calculations make us feel a little bit better. So we we often put it on about 100 mils per kilogram per minute. That's, if you look in the textbook, that's going to be the recommendation. And I think, once again, that is just a calculation for comfort. Personally, practically, I just turn that flow up in my circle system to like 2, 3, 4 liters per minute. And then I make a note. I put little wee asterisks on my anesthetic record, and that's when I know that I can readjust and go down back to a nice normal maintenance flow of about 0.5 liter per minute for most of my patients under anesthesia. And I think the important thing is when we move our patient from one theatre to the next, and perhaps it's a different circle system, you have to do the same thing all over again. When you are sure perhaps the patient was only just in there and actually that system is still filled with this really high concentration of oxygen. But if in doubt, if I can't measure the levels of oxygen that's been provided, as in with an oxygen analyzer, I just turn it up. I just turn it up for 10, 15 minutes, and then I turn it down, back down again. So yeah, we're just needing to push out that room air and fill it all up again.
Yeah, so you're right. It's a long word which sort of implies something quite, technical going on.
Yeah,
really,
like a mad scientist. Like
we're going from room air, which has got 21% oxygen and 79, 80% nitrogen. We want to be up nearer 100% oxygen, so we just got to get the nitrogen's got to be removed effectively, and it's not actively removed; it's just displaced by the fact we're pouring in oxygen, and it takes time for that to happen. And people will talk about time constants for circuits, and you need 5 time constants to make a change. But of course, it's not just the circuit, as you just said, it's the circuit plus the patient. So if you've got a 30 kilo Labrador, you've probably got 1 liter or more of FRC, reserve lung capacity, which adds to all the circuit volume of the apparatus as well. So it can take quite a time, and that's why you need that period. But of course, if you were to have an oxygen analyzer in circuit, you could tell very quickly when you'd got to that, denitrogenated state, and then you can just turn the oxygen down then, rather than assume the worst, assume a long period. So you could just, with that sort of monitoring capability, you could possibly get to a reduced state a lot earlier. I'm sure you would get to reduced state. Could all play safe, don't we? So
we always play safe, don't we, with oxygen?
Yeah.
And I think that probably also brings in a discussion, just talking about circle systems, about oxygen concentrators and how to use our oxygen concentrators. So just like Keith mentioned before, they can concentrate pretty well. About, what is it? It's kind of anywhere 93, 97-ish%. So what's actually happening with that oxygen concentrator is it's taking in the room air, and then we have like a little sieve, a zeolite-based sieve in there, and that absorbs the room nitrogen, that absorbs what's in the atmosphere. So it absorbs the nitrogen, and therefore it then bulks up and concentrates the oxygen. However, there's still actually the third most abundant gas in the atmosphere. So we've got, of course, we don't just have oxygen and nitrogen. We've also got lots of little other gases. We've got argon, we've got xenon in different concentrations. But there's only 1% or so of argon in the atmosphere. And this is something Keith says, he's not friends with argon, really, are you?
No. It came as a bit of a shock, this argon thing, because when you go through school, I remember going through secondary school, and you're told that air is 21% oxygen and it's 79% nitrogen. So you're happy because 21 and 79 gives you 100%, doesn't it? So
yeah,
my brain said, okay, that's 100%. And then you go to university and they tell you, well, that actually, it's not 21, it's 21, it's 20.83, and it's not 79, it's 78 point something, because you've got some of these other elements in there. And you've got xenon, you've got argon, we've got all the inert gases. But yeah, there was still never enough for 1%. And I think someone mentioned this a while ago, maybe you, Courtney, you was 1%. I went, it can't be 1%. There's just not enough room to squeeze that into the.
We don't have 101% of gases in the atmosphere.
So I went off to look it up. I went off to look it up, and I found everywhere, yes, it is. Well, it's 0.93, I think, is the official amount. So I was really quite surprised and quite disappointed that my life so far I've been sort of misled as to the amount of argon in the atmosphere and how I could get to this age without realizing it. But it's quite important because Because concentrators concentrate, they take 21% and turn it to 100%. So they do a 5%, or sorry, a 5 times concentration ratio. And they do that to argon, don't they?
Well, yeah, exactly. By removing the nitrogen, then we are only left over with the oxygen, which is concentrated, but also we can end up concentrating the argon because our sieve doesn't get rid of that. It's not absorbed by our oxygen concentrator. It absorbs nitrogen only. So actually, whilst there's about 1% of argon in the atmosphere, or 0.93, while we've still got, I'm looking at you thinking, are you boiling over there? The sneaky little gas. Although we only have 1% of it in the atmosphere when it's with its other gases, when we put it into a oxygen concentrator and then run really low flows in a circle system, actually we have the potential for that argon to build up. And it ends up concentrating to about 5%, I think. It just ends up being there. We concentrate our oxygen, we concentrate our argon to about 5%, and we don't have our nitrogen. Fantastic. And I think that brings us to the point, so how do we apply that practically in our patients? And I think all we need to be mindful of is that a buildup of argon is going to displace the amount of oxygen available to our patient over a long period of time at specific flows. So actually, when you're using an oxygen concentrator, it is recommended when you're using it with a circle system not to go lower than 0.5 litre per minute, which I don't think many of us are doing anyway, because we might not have those vaporizers that can deliver that accurate concentration that low. And interestingly, there was a human study where they did closed circle system anesthesia. So we only provide kind of the metabolic rate for our patients at really, really low flows. And it did actually concentrate up to about 40% of argon after an hour and a half, so about 80 or so minutes. But we're not doing that in our veterinary patients. We're not running our closed systems unless we're monitoring with agent kind of multi-parameters that telling us how much oxygen concentrations in that system, or with an oxygen analyzer. But still interesting to know it will concentrate, and it's not the argon itself that's the problem. It's the fact that it displaces the available amount of oxygen to our patient. But you need quite a long period of time and quite a low flow, because our patients are going to be fine with some slightly lower oxygen levels as well. We're not really going to get into a problem until we're less than about 30 or so percent oxygen.
But it's interesting, the principle of one gas displacing another, and like argon, and more or less ignored most of the time, but it could potentially have an effect. So I think it's interesting to know how these things work, because if you understand how they work, then you can understand the effects that they might have. I think a slightly different vein, but there is one thing we should talk about again that might affect oxygenation, and is this concept, or this phenomenon of diffusion hypoxia. Have you heard of diffusion hypoxia? Yeah. It's it's diffusion hypoxia is a real thing. Yeah. Well, maybe not quite so prevalent now. I don't know how many people out there are using nitrous. I know it's becoming less and less favorable, particularly now with environmental concerns. But if you hear about things like diffusion hypoxia, then it's something it's just a process that occurs naturally, or it's just a standard process, nothing that you have to do. It's just that if you are running a patient on nitrous and you go from a period of stabilization where the patient's stable, has got oxygen coming in, CO2 is being removed correctly, they're not hypoxic, and they've got a stable amount of nitrous on board. When you turn that nitrous off, you change the dynamics enormously from this stable diffusion pathway from the lungs into the blood, completely the other way around. Now you've got no nitrous in the lung effectively, and you've got a lot of nitrous in the blood. So what happens is the nitrous pours out of the blood into the alveoli and fills them up. And in so doing, it displaces or reduces the partial pressure of oxygen and CO2. So during that initial period of disconnect, you've got a reduced level of partial pressure of oxygen and CO2 in the lungs. So they become hypoxic and hypocapnic. And hypocapnia will just serve to not stimulate the breathing, so they can be less inclined to breathe. And the hypoxia will give them a reduced oxygen delivery, so they will become hypoxic, and that itself may have its own effects. So just to be aware of that, there is this thing called diffusion hypoxia. That's on the recovery. A similar effect occurs when you start up. You rather than getting a reduced level of oxygen and CO2 in the lungs, the effect of the nitrous being in the breath and then rapidly absorbed will give you an increase in partial pressure of oxygen and CO2 in the lung. So you get initial hyperoxia in the lung, and you actually get a little bit of hypercapnia. But it's the main effect, really, the sort of clinical effect that you would worry about would be during the recovery.
It was about 10 minutes or so you turn off your nitrous and you keep your oxygen on just to make sure they're getting, and also I think it's good for our environmental pollution, ourselves in the theatre. But yeah, about 10 or so minutes they recommend keep them on oxygen after stopping that nitrous delivery.
Yeah. So I think we've covered a few things. One thing maybe I don't know how the time's going, but one thing maybe to think about now is if you did have access to a blood gas analyzer, what could you look at on there that would give you an indication of something being awry? So you suspect a hypoxia, you suspect that your oxygen saturation that your pulse ox is telling you is poor. If you had blood gas analysis, then that would give you more information and more weapons to sort of prove this problem. A couple of things that I think we would look at there is, you get the PaO2, don't you? You actually get the big, the partial pressure of little a, the arterial oxygen levels, and that will tell you a lot, because we talked again last time about the big A to little a gradient, which is normally 10 to 15 millimeters of mercury in young dogs, young cats, and increases with age, but still not that high. So you're still looking to see in room air P little AO2 or something like 80 millimeters of mercury plus. And if they're on 100% oxygen, that should be up in the hundreds. I mean, theoretically, they're on 100%. Oxygen, should be up in the sort of the 600s. So that would tell us, whether we had a true PaO2. But even if you didn't have that, or in addition to that, you could look at lactate, couldn't you? Because one thing we're going to see with hypoxia is insufficient delivery of oxygen to those tissues. So we're going to get a lactic acidosis effectively. So we should see a lactate response as an indicator of hypoxia, and that's called that's type A hypoxia. That's a typical hypoxia where you get a lactic acid response. So these are possibly more long term. It's not minutes, but it would be an indicator of hypoxia. So
anaerobic metabolism there, isn't there?
Exactly. Yeah, because you haven't got that oxygen there, so you're going into that anaerobic metabolism, producing lactate as a byproduct, and that'll give you a lactic acidosis, so your lactate levels will go up. So if people have got those, then I think you could use that as a tool. If you really have a dog that, or a patient that you think is hypoxic and you want to prove it, and then obviously try and do something about. If you had access to a blood gas analyzer, that would give you further information that might confirm your worry about hypoxia, because you may not necessarily see that clinically. Okay. What else we need to just finish up on now? I think, Courtney, some final thoughts.
Yeah, I think we've covered quite a lot. We've done our, talking about our pulse ox.
Yeah.
And about, you can confirm it with your blood gas. You can do the same with capnography, confirm it with your blood gas. And one of my favorite things, and it's very much a luxury, is to know the percentage of oxygen I am delivering to my patient. It isn't just that flow meter. What's the flow meter set at? It's kind of what I can actually give my patient. And we know that it doesn't have to be a big inbuilt module on your multiparameter, which, like you said, costs about £1,000 to £1,500. You can get them now, the size of, your closed fist, really, isn't it? I like to say the size of an iPhone, but that implies it's very skinny. So, it's oxygen analyzers that just go anywhere on the system, that the size of your closed fist. And perhaps, how we can troubleshoot that hypoxemia from hypoventilation as well. Is the patient shivering to give them oxygen? Do they have thoracic pain that's stopping them taking a deep breath and hyperventilating. Give them some analgesia. Is there some sedation drugs that are causing them to hyperventilate? Can you antagonize some of those sedation drugs then? Are they really cold? Well, warm them up. Are they shivering? A shivering patient, I'm giving oxygen to that patient. Or do they have some kind of central, I don't know, have they been hit by a car and they've got raised intracranial pressure as well? I'm kind of thinking that I'm probably going to be hyperventilating from that. I'm going to give them some oxygen. So I think we readily do give our patients oxygen in the hope that it's a hyperventilating reason.
Yes. And we have to remember that giving them oxygen isn't always enough. We might need to augment that ventilation ourselves, because their ventilation rate may just be too low.
Yeah.
We don't need, we shouldn't forget that all those mechanisms to stimulate ventilation may be impaired, and it may actually be painful or even physically difficult for them to do. Pressure on the diaphragm, things we talked about before, restraining chest, physical embarrassment to breathing. So we might need to manually ventilate as well.
And I guess for those cases of anemic hypoxia as well, I like to think in those acute anemias, we have to think about transfusion, not just from a volume replacement, but also we lose that ability to transport oxygen. But actually in some of these, these chronic cats with their 9% PCVs, sometimes we've just got to treat the disease process that's making them, that is destroying their red blood cells versus trying to transfuse these guys. But I think with anemic hypoxia, we can transfuse them. We can suspect perhaps on their clinical history that they're anemic. We can feel their 3D pulses. There's that murmur that's there in those anemic patients that perhaps wasn't there before because the blood viscosity's changed. It's not so full. So I think we've touched heavily on what would be a hopeful, easy fix with a bit of hypoventilation versus these other crazy hypoxemias.
Okay, I think that's good. We'll probably wrap it up there for our sort of 3-part oxygen discussion. And I think we've got a lot we can talk about on, a couple of things. I think looking to the future, I think a discussion on, more in depth on pulse oximetry, the device itself, how it works, where you place it, the limitations of the device, things like that. And maybe we could also, on another podcast, think about things like getting more information out of, or discussing the information you get from blood gas analysis, whether it be venous or arterial. There's a lot there. I think we've talked about respiratory acidosis back in some of the early talks about ventilation. So it'd be nice to bring that in and talk about how you can monitor that and how you can tell whether you're dealing with a metabolic or respiratory or mixed acidosis, those sort of things. I think there's a lot of terminology in there that frightens people. Lactate levels, bicarbonate levels, those sort of things. I think we'll save that for another time. I think that's something I quite like to talk about. But for today, I think we've done a lot. And we look forward to the next one. The next podcast is going to be talking about, in a similar way that we looked at the passage of oxygen. We're going to look at the passage and distribution and removal of carbon dioxide in the next podcast.
Next 3. Yeah. Fantastic. Okay. Thanks for that, Keith.
Hello. Thank you, Courtney, and speak to you soon.
Talk to you soon. Thanks for listening to this week's podcast. Don't forget to follow our podcast to stay up to date with the latest episode, and feel free to share with your team. If you have any questions or feedback for us, or simply want to know more about what you've just heard, please send us an email to clinicalsupport@burtons.uk.com. Catch you next time.